Welcome to the Codecast Podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast Podcast. My name is Terry Fletcher. Hopefully, everybody's having a good start to their fall season. It is the end of September, and we are at Top 10 Tuesday, the last day of the month. So you know what that means? That means we're going to talk about the top 10 coding, billing, reimbursement, management questions that I've received over the last month or so. Actually, probably over the last 2 months. I've received so many questions lately to be addressed. And then also, one of my questions actually is going to be all about acronyms. I mentioned it last week in my business collective roundtable for those of you that joined me. And then that's going to be one of my biggest questions. So we may get to 10 questions, but I think that's going to be probably at number 7 when we get there. But there's so many of them, it'll feel like 10. But first, we'd like to thank Anesthesia Billing, ABC, offers seamless physician billing and practice management software and services to thousands of anesthesiologists and CRNAs nationwide. AnesthesiaLLC.com. And also, Medical Economics, smarter business, better patient care. Follow them for the latest news and viewpoints on primary care, specialty care, the business of medicine, and health IT. medicaleconomics.modernmedicine.com. Smarter business, better patient care. Okay, so let's just dive right in. And the first thing we want to talk about as far as our top 10 question, it comes from ICD-10. And so let's take a look at that. So my first one says, Terry, I'm frustrated. In ICD-10, which we know that's our diagnosis coding, if a patient has mitral valve regurgitation without mention of it being non-rheumatic, in the report, would we use the rheumatic diagnosis code? We were told the correct way to code is with the rationale that if the documentation does not specify rheumatic or non-rheumatic, we would assign the unspecified code, which is also a rheumatic code. However, other coders in our office has always been taught to code as non-rheumatic unless stated otherwise. It seems wrong to give a patient a rheumatic condition, which you know means that they've had a past episode of rheumatic fever or they've had some kind of rheumatic condition. Seems almost backwards. So what would you have us code? Because we don't want to presume that we code something with a default of rheumatic when it actually isn't. Okay, so first of all, I feel your frustration. I agree that coding something non-rheumatic unless otherwise stated would be like giving a patient a condition without any backup to support it. And you don't want to make that presumption, of course. However, the official guidelines for ICD-10, and again, I may not always agree with them, but we have to follow them, as well as follow the AHA, which is the American Hospital Association coding clinics, and CMS guidance. So here are some of the heart disease rules of thumb to follow. A singular cardiac device disorder stated as unspecific or non-rheumatic is coded with a non-rheumatic code. But you'll notice what I said there, stated. Okay, so the doctor would have to say that. A singular cardiac valve disorder stated as rheumatic is coded with a rheumatic code. That's easy. Multiple cardiac valve disorders involving multiple valves stated as unspecified or rheumatic are presumed rheumatic and coded with a combination rheumatic code. And then some multiple cardiac valve disorders of a singular cardiac valve. So let's just say a mitral valve stenosis or a mitral valve insufficiency. They are actually presumed rheumatic and coded with a combination rheumatic code, even though multiple cardiac valve disorders involving multiple valves are not documented. It's unfortunate, but unfortunately the coding guidelines that we have to follow default to the rheumatic code. So this is where it's a big learning curve for your physicians. Tell them, be specific, or I have to actually default to a diagnosis that doesn't give the complete clinical profile of that patient. It's making some assumptions that you did not include in your record. Question number 2. The cardiologist documents a diagnosis of left ventricular failure caused by hypertension. What ICD-10 codes should we report? So this is an Alaska subscriber. Since hypertension is the cause of heart failure, you're going to look at the I11.0 code, and that is hypertensive heart disease with heart failure. So just note that the I11.0 indicates you must report an additional code from the I50 series to identify what type of heart failure, which in this case would be I50.1, left ventricular failure, unspecified. That was actually a new code from last update from last year. So remember, code first notes indicate the primary reason for the diagnosis, and maybe that is the main cause for this other diagnosis as well. And also note that there's a presumed causal relationship between hypertension and heart involvement, and between hypertension and kidney involvement, because they're linked with the term with, which is what was included here. So we just want to make sure that we're clear on that, otherwise that can be an issue. Okay, so now I'm going to switch gears a little bit, and I'm going to look here to what we call a nursing home visit. So this is something that came up recently, and I thought it was interesting because I got a lot of different feedback, a lot of different comments on this question. So question comes up, and basically they're talking about the initial visit for a physician that is seeing a patient in a skilled nursing facility or a nursing facility. It doesn't have to be skilled nursing, but who is the one that can actually code for it? Well, I looked at a MedLearn Matters article, which is the outreach and education for Medicare, and it was the article 4246, just to get a clarification. And what it really talked about is that the initial assessment for a nursing facility or skilled nursing facility, that encounter required by regulations, so it's called the regulation admit visit to the facility, means that only a physician can admit the patient to the facility because, again, it's a facility admission. They can be new or old to the practice. There are the codes 99304 to 99306. Now, the codes are still the same codes for new patient encounters for nursing facilities, and that's also what you use for Part B billing. The problem is that a PCP can admit a patient using the appropriate code, but then let's say a wound care nurse practitioner who's doing a consult, we don't have consult codes anymore, they would, for that new patient encounter and different service, they would actually use the same code. So that would be an example of maybe two admissions. One would be allowed at 100%, one would be allowed at 75% based on the information that comes out with that rule. And CMS puts out this rule, conditions of participation for nursing facilities. It's not a Medicare Part B rule. It's really a rule that has to do with admissions and facilities. So that one was kind of interesting when I was taking a look at that. So just wanted you to be aware of that. That was a question that came in that was kind of an unclear, a little bit of risky question. So I'm going to revisit the chronic care management for my next question. This is question number 4. So payers and the Office of Inspector General are really starting to crack down on improper payments for chronic care management, CCM. And so I wanted to address this because I got a question from one of my Kansas subscribers to my Coding Corner on-demand service. And basically she said, we are getting denials for CCM and we're not sure what the problem is. We have a third party that set up the CCM within our office, and now we're seeing denials all over the place. So can you just explain to us why we would see denials and basically how to fix those denials, or how to avoid it? Okay, so here are the couple of things that the OIG is looking at, and also Medicare. If more than one provider bills chronic care management for the same patient during the same 30-day time period, that's going to be a problem because it's duplication, especially with the same diagnosis. So you want to coordinate care with specialists to avoid that duplication. This coordination should occur at the physician-to-physician level. It's usually primary care and the specialist. They really need to collaborate and decide who's going to perform all or a majority of the care management activities, including addressing the patient's psychosocial needs. And whoever does that, that's the one that gets to code for it. So again, there's also some other things here. So here's one. The practice bills for CCM with home healthcare supervision, so hospice care. So the code's G0181 or G0182, certain end-stage renal disease services or transitional care management services during the same 30-day period. So you're going to get denials there unless you get your software vendor to include an edit that prevents the practice from billing CCM with these other services, or they need to hold the claim till the last day of the month to make sure that the patient who is enrolled in the CCM hasn't already had those other services performed, because they are inclusive of these other services. So really be aware of that could be kind of an interesting situation. Now, one of the biggest issues for denials, and this is, I think, what you're probably seeing, one is the care plan is too generic or the CCM services are not appropriate for the patient. So if the comprehensive care plan only addresses the minimum qualifying 2 chronic codes, then you're going to have a problem. So just be aware that that's going to be an issue, and I don't want it to be an issue for you. That's just going to be such a nightmare. Okay, so our next question number 5, we are looking at some additional diagnoses. And somebody said, Terry, I have a patient that actually has a withdrawal disorder from cannabis use. And so we know now that in many states, since this is legal, we're having all kinds of medical conditions related to overuse, overutilization, and now it's dependent. So now we have cannabis dependence. But we have some new codes that are going to take effect October 1st on the ICD-10 lineup. And these actually are added to the mental, behavioral, and neurodevelopmental disorder chapter of ICD-10, and that's the category F12 section. So F12.23 will be added as cannabis dependence with withdrawal, and then F12.93 is cannabis use unspecified with withdrawal. So you will have some options come October 1st. Right now, all you really have are some codes that are cannabis dependence with or without intoxication, or with psychotic disorder or with delusion. So it's interesting that this section exploded with all of the use and all of the medical issues now that are happening within that genre. Okay, and then one of the other questions has to do with HIPAA before we get into our acronyms. And you want to stick around for our acronyms. I really find this is going to be an interesting segment. So what does HIPAA say about maintaining patients' private health information after they die? So if a patient passes away, that does not make his or her Health Insurance Portability and Accountability Act agreement null and void. In fact, HIPAA privacy rule protects a patient's individual identifiable health information for 50 years after the date of death, according to the HHS Office for Civil Rights. So during a 50-year period of protection, the personal representative for the decedent, okay, so the person under the actual applicable law, with authority to act on behalf of the decedent or decedent's estate, has the ability to exercise the rights under the privacy rule with regard to the decedent's health information, such as authorizing certain uses and disclosures of the information or gaining access to the information. But that's under the OCR in 45 CFR HIPAA privacy rule. So just know it's 50 years. It's not just gone away just because the patient has died. Okay, so I wanted to get into what I call kind of the alphabet soup of clinical lingo. So I touched on it last week, but I got a flood of emails recently, and I got some direct messages on my social media accounts. And somebody said, we are in a nightmare of some of the things that the doctors are starting to document, and they put these acronyms in their notes. And so we're not familiar with some of these. Can you please address some of these? And I got them all over the place. You name the specialty, it's everywhere. So this is a kind of a big area. So let me start with some of the most recent ones. So DM, diabetes mellitus, HTN, hypertension, CHF, congestive heart failure, OA, osteoarthritis. One of our management ones, which is RCM, revenue cycle management. Okay, so it's really another word for collections, in my opinion. VVA, virtual voice assistance. Okay, or assistant. OTC, over the counter. So over the counter medication, you might see that. In an exam, you might see JVD, jugular vein dissension. How about HEENT? So somebody said, I don't know what that is on the exam guidelines. Okay, so H for head, eyes, ears, nose, and throat. Okay. If somebody says cores, that's coronary. So they're looking at the coronary vessels. I think my favorite one when somebody asked me, what is FLU? No, it's F/U for follow-up. It's not flu, it's follow-up. One of my favorites, PRN, patient return as needed. Remember, as from an auditing perspective, when I see that and I see a practice trying to bill for a level 4 or 5, that's not moderate or comprehensive or high level of medical decision making. You put now the care of the patient in their own hands. And so if you put that in an encounter, that means that it's probably either straightforward or low complexity medical decision making. COPD, chronic obstructive pulmonary disease. TIA, transient ischemic attack, versus CVA, cerebral vascular accident. So this is when the patient has an episode of loss of consciousness. One is with, one was without. PCI, you've heard me talk about that before. Percutaneous coronary intervention. BP, that's an easy one. Blood pressure. Okay, so you're going to see that on quite a few areas. How about CVB, Group B, Cox-Sackie virus. IBS would be inflammatory bowel disease. NPP, non-physician practitioner. And the reason I'm going through these is some of you may go, oh, I've been wondering what that is. We also have PVI versus PVD. So PVI, peripheral vascular insufficiency. PVD, peripheral vascular disease. DU would be a decubitus ulcer, so a patient who's got lower extremity vascular disease, and then they've got an ulcer or a sore that will not heal, and then it has to be debrided. That's what the DU is. GOO, gastric outlet obstruction. H reflex, Hoffman reflex. How about LAVA, LAVA, laser-assisted vasal anastomosis? Remember, the anastomosis is where a certain body or area of intestine connects. LBM, last bowel movement. LCF. Okay, so somebody put here left circumflex. Okay, you're going to also see LCX. Okay, X is an X-ray, so left circumflex artery. NTS, so N is in Nancy, T is in Tom, S is in Sam, nasotracheal suction. PCL, pacing cycle length. How about RLQ or LLQ? I bet most of you know what that is. That would be right lower quadrant versus left lower quadrant. SMD, senile macular degeneration. How about SNP, simple neonatal procedure? And then a new one I've seen quite a bit, and I haven't realized that this was something that was seen in a clinical side. WBE, weeks by examination. So that's kind of a big one there. So you always want to make sure that's only some acronyms. I've given you basically 2 handfuls of them, but you want to be updated on it. Make sure you're Googling your acronyms as well, and then verifying with your physicians. Don't assume that they're saying something in the documentation that you're not aware of what it is. Otherwise, that can be a really bad assumption and could be really, really a problem when it comes to making sure that your record is accurate. So we don't want to do that. And lastly, we'd like to thank our last sponsor, Health Tech Magazine. They serve as the leading source of information for forward-thinking professionals involved in healthcare. HealthTechMagazines.com. So everyone, I hope you're having, again, a good fall start and everything's going well in your practices. This is the time before we really dive into 2019 information that you take your education classes, sign up for webinars. Look on my website. We've got a ton of fall webinars, seminars, conferences, audio classes, you name it. And one of the things somebody asked me, they said, do you actually do private webinars where you'll gear an actual education workshop for a specific practice? I actually do. So contact me through my website at terryfletcher.net. Go to the contact form or email me directly at terryfletchercpc@aol.com. And just a reminder before we close today, make sure that you take a look at my website, look at my blog, see what's up there, because we have a lot of information, a lot of photos of things that are happening. I just spoke at the AAPC Regional Conference in Hawaii. Just such a great, group of people, and it was just so positive and fun. But you'll get to see some photos for that. And then breaking news, you'll see articles on that and some links to articles as well. And then also our fall schedule. So we'd be happy to address anything that you need. Also, I have my new books out. So if you're interested in a specialty coding book through PDF, it's an ebook publication. Please, again, go to my website, look at products, and we'll have some information there for you. So everyone, make it a great day, and thanks for listening, and we'll see you next time on the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.